Just wanted to read a little bit of information about her. Heather Gallivan, PsyD LP, is the clinical director at Melrose Center. She joined Melrose in 2004 and has worked with eating disorder patients in all levels of care, from outpatient to residential treatment settings. She obtained her doctoral degree in clinical psychology from the Minnesota School of Professional Psychology. Prior to joining Melrose Center, Dr. Gallivan served 5 years in the United States Navy as an active duty psychologist. She is a passionate leader and teacher concerning the prevention and treatment of eating disorders and how societal messages impact our beliefs and attitudes about food, weight, and body image. And so without further ado, Heather, thank you for joining us today, and I'll pass it off to you.
Thank you so much, Abby, and I'm really excited to be here this morning. This is really one of my favorite things to do, is to educate others about eating disorders. And our timing on this today is really perfect because it is National Eating Disorder Awareness Week. So I feel like Melrose is doing their part to get the word out about eating disorders. So today I want to spend some time just talking a little bit about Melrose Center and our programs, a little bit about eating disorders, and then some exciting things that are happening here at Melrose Center. So Melrose Center, we have been part of the Park Nicollet and Now Health Partners organization for more than 35 years. And we have been in our site, beautiful site here in St. Louis Park, for almost 15 years. It's incredible to me that that much time has passed. But at Melrose Center, we have expanded many times over the years, and we have what we would describe as a hub and spoke model, where our hub is our beautiful location here in St. Louis Park. This is our largest site, and this is where all of our higher levels of care are concentrated. So here in our St. Louis Park site, we have 39 beds total. They are all licensed as residential beds through the Department of Human Services here in the state of Minnesota. And we currently have those divided into a more intensive residential unit, where we are able to care for more medically complex patients, and then more of a traditional residential unit. We also here at St. Louis Park have a partial hospitalization program that offers services to both adolescents and adults, 8 hours a day, 5 days a week, and typically that program runs for about 4 to 6 weeks. We have an intensive outpatient program for adults here as well. That is a program that meets twice a week in the evenings for 3 hours over the course of four weeks. And then we have many other group programs here. We have a very large binge eating disorder group program. We have a family learning series for our parents of adolescents. We have a family support group. And we also have a comprehensive DBT skills program here as well. And then in St. Louis Park, this is also home to our largest outpatient site, where we do initial assessments and offer the full range of outpatient services for our patients here. In addition to St. Louis Park, our spokes are 4 sites throughout the Twin Cities area, one in Maple Grove, one in St. Paul, which is conveniently located just on the Green Line, right off the Twin Cities U of M campus, one in Burnsville, and one in Woodbury. At all of these sites, we have a full outpatient team that consists of a primary care provider, therapists and psychologists, and registered dietitians. At these sites, we offer initial assessments as well as outpatient follow-up. And then since the pandemic, we are also lucky that we are able to offer video visits. And I think that's really reduced a lot of barriers to care for people, as well as having kind of our satellites out in the communities. So why do we need all of these sites and facilities? Well, one reason we need these sites and facilities is that really, although a lot of people don't know much about eating disorders, the reality is that the prevalence of eating disorders is on the rise. And there are about 28.8 million Americans who will suffer from a clinically significant eating disorder at some point in their lifetime. And we know that eating disorders impact about 9% of the population worldwide. And what we have seen over the throughout the 2000s is that the prevalence of eating disorders in terms of the percentage of people with eating disorders across the general population is on the rise. So in the early 2000s, what prevalence studies told us is that eating disorders affected about 3% of the general population. Newer prevalence studies, which when I say newer, unfortunately, newer means about up to 2018. So we don't really have great data yet on what has transpired over the pandemic. Those studies are showing that about 8% of the population here in the United States is struggling with an eating disorder. So we are seeing some shifts here, and it's important to continue to raise awareness because only 1 in 5 people with eating disorders ever will seek specialized eating disorder treatment. A lot of times people with eating disorders end up in general healthcare settings, general mental health care settings, seeking care for things like depression, anxiety, some of the somatic or physiological effects of eating disorders, but they aren't necessarily going in and asking for eating disorder help. And the problem with that is that oftentimes then the eating disorder is not addressed and continues to be a big part of the person's life. The other thing it's really important to note with eating disorders that I like to really raise awareness of is that eating disorders have one of the highest mortality rates of all the mental health diagnoses. They used to actually be in the top spot, where unfortunately they were the most lethal, but they are, opioid use disorders have taken that top spot, and eating disorders now are just underneath that. And when we think about mortality with eating disorders, that can kind of happen for 2 reasons. One, unlike other psychological disorders like depression and anxiety, eating disorders also, they have a psychological component, but they also have a significant physiological component and can impact people very significantly in terms of their physical health. And so some people with eating disorders die as a result of the physical complications of their eating disorders, most notably cardiac types of events. The other unfortunate thing that happens with people with eating disorders is that they can die from suicide. And about 35% of people with both anorexia and bulimia will attempt suicide at some point in their illness. And people with anorexia in particular actually are highest risk for suicide. And we know from some really good research at the University of Minnesota actually that people with anorexia are 23 times more likely to die from suicide than sort of the general population. And that's actually higher than other psychiatric illnesses. So depression is about 20 times higher than the general population to die from suicide, and bipolar disorder is 15 times higher than the general population. So one passion area of mine is to continue to kind of challenge, what does an eating disorder look like? So unfortunately, I think the perception still remains that eating disorders impact thin, white, young girls, mostly from middle to upper class backgrounds. And that's actually not true. And the reality is that eating disorders don't discriminate. Eating disorders can affect people of all racial and ethnic backgrounds, sexual orientations, body types and sizes, gender identities, and ages. And so I just want to spend a minute kind of diving into this a little bit further because I think it's really important. And so when I think about the different diversity in eating disorders and what we see, I think about a few different buckets. One of those being people from different ethnic or cultural backgrounds. And really what we know is that people of color with eating disorders are significantly less likely than Caucasian individuals to have been asked by a doctor about eating disorder symptoms and to ever get treatment or referral to eating disorder care. Despite what we know is that there are similar rates of eating disorders across all ethnic groups. And so this is a really important topic where people are not getting the care that they need. Eating disorders impact all kinds of bodies. So the perception, I think, really remains that eating disorders occur in individuals who are underweight, when in fact, the reality is only 6% of people with eating disorders actually are considered kind of medically or clinically to be underweight. And so again, a lot of times people with eating disorders fly under the radar because we are kind of looking for a certain type of body to be concerned. Eating disorders affect all ages. So I have two kind of squares about this on my slides. Rates of eating disorders and body dissatisfaction are on the rise later in life. So here at Melrose Center, about 30 to 35% on average of our patients that we treat here are 35 and older. And that always surprises people. On the other end of the spectrum, we are seeing eating disorders at younger and younger ages. And I'm going to spend a minute more on this in just a moment. But also at Melrose Center, on any average year, typically our average age range that we treat here is about 8 to up to 80. I think in 2023, our high age was 69. And so that also often surprises people. 1 in 3 people struggling with eating disorders are male. Eating disorders are admittedly the most gendered of all psychiatric disorders. However, we are seeing a rise in eating disorders in boys and young men. And what we have seen here at Melrose Center throughout the pandemic is about a 20% increase in the number of men and boys coming in for treatment. And we also know that in the United States, male teen body dissatisfaction has tripled over the last 25 years. And although body dissatisfaction does not equal someone developing an eating disorder, certainly it can be a factor that puts people at risk for the development of an eating disorder. We also know that men are much less likely to seek treatment for eating disorders, really due to kind of the remaining stigma that this is sort of a quote unquote female disorder. And then our LGBTQ population. So within these communities, gay and bisexual males, as well as transgender individuals, are at higher risk for eating disorders. We know that about 63% of gay males base their self-worth on their weight. And we know that the prevalence of eating disorders amongst transgender individuals is considerably higher. Many studies show about double the rate of kind of compared to the general population. So a high-risk group, and one that if you work in a clinical setting, it's important to have that on your radar and be systematically screening. I want to take a minute to talk specifically about young children and eating disorders and kind of adolescents as well. One thing we have seen here at Melrose Center that started right around the time of the pandemic and has continued to the present day is a huge influx of young people coming for care here at Melrose Center. And that has been echoed across the United States and really across the world. When I go to conferences, everyone is talking about this influx of young people developing eating disorders and coming for care. Specifically here at Melrose Center, what we have seen is about a 40% increase in the number of adolescents coming to any of our sites for care. And we also have seen a large increase in the number of young children and adolescents needing admission to our residential program. So philosophically, as a program with our younger people, we really try to avoid things like admission when we can, because we want to keep people with their family and in their day-to-day lives. And unfortunately, we've seen a big increase in this. Through 2023, we had a 20% increase in the number of kids being admitted to our residential unit. And I just got data including 2024, and that it's jumped up to 36%. So definitely a shift here. What is going on? I get asked this all the time. What is going on? Well, I think it's pretty safe to say that the pandemic and things related to the pandemic that happened with schools shutting down and activities shutting down and more isolation has not been very good for the mental health of our youth in our society. I think also during that time there was really a boom of people spending more and more time on social media and less time connecting kind of interpersonally in real life. And so those things, along with other things, have created kind of this situation that we find ourselves in. A few things to note: young children and eating disorders, we really are seeing growth in children kind of under 12, children as young as 8, presenting with traditional eating disorders. Mostly these younger kids are coming in with anorexia and ARFID. And what ARFID stands for is avoidant restrictive food intake disorder, and it's a type of feeding disorder. Oftentimes these young folks their eating disorder is starting by going on a diet. Almost always they have kind of a preceding anxiety disorder, so generalized anxiety disorder, OCD. Oftentimes these younger individuals are very perfectionistic. Lots of younger people engaged in sports activities. And in 97% of the cases with young children and eating disorders, they are avoiding certain types of foods. So they start to kind of cut out entire food groups. The other thing we're seeing is sort of this rise in children kind of with more chronic illnesses that oftentimes require adherence to a more limited sort of dietary meal plan, can also be a pretty significant risk factor for the development of eating disorders. So things like type 1 diabetes, celiac disease, IBS, those sorts of things. So really my message here is that anytime a child is losing weight, even if they are in a larger body, that is something to take note of and screen for eating disorders. So these are the different eating disorders. So this is what we use in the medical field to diagnose the different eating disorders. And I'm not going to go through all of these, but really they are anorexia, bulimia, binge eating disorder, avoidant restrictive food intake disorder, and we have 2 other categories. And those are really for people who don't neatly fit into the above 4. Of kind of anorexia, bulimia, binge eating disorder, and ARFID, binge eating disorder is the most kind of common of the eating disorder, and it actually has the most equal prevalence between males and females. And really, truly, probably our other specified feeding or eating disorder remains kind of the most diagnosed of the eating disorders because it is challenging to categorize people in neat buckets. The other thing I do want to take a quick note of, because it is another sort of area that we're seeing an increase in, is something that is called atypical anorexia. And where this falls in the DSM is under that other category. But what this really is these are individuals who are meeting all of the criteria and engaging in all the behaviors related to anorexia, but they are not considered medically to be underweight. However, these individuals are losing significant amounts of weight. So they oftentimes are presenting with greater weight loss from higher starting points, but they have very comparable eating disorder symptoms, not only psychologically, but physiologically. So although, these individuals may present in a primary care type setting or at the pediatrician, and their BMI is in the quote unquote normal or healthy range, they are quite medically compromised. And unfortunately, because of kind of that normal BMI, they often go unrecognized and delayed in terms of getting treatment for long periods of time. Because I think we all know in our society, when people lose big amounts of weight, what happens? Well, what happens is that we get a lot of positive praise and reinforcement for that. You look so great. What did you do? What's your secret? Meanwhile, this individual may be in the throes of an eating disorder. So again, this is typically also seen in adolescents and young adults, and it's something to be aware of. Other kind of high-risk eating and activity behaviors that can be red flags for eating disorders: anytime someone's engaging in severe dietary restriction, where they kind of have a limit of how many calories they are restricting. I like to use anything kind of less than 1,000 calories a day, because the reality is, even as adults, that is a pretty restrictive nutritional intake for us to maintain kind of our body's needs and our daily activity needs. Anytime someone is skipping meals with the sole purpose to lose weight, and they're doing that repeatedly, prolonged periods of fasting outside of for religious reasons, anytime someone is making themselves throw up to get rid of food, that is definitely a serious red flag and something to be concerned about. When people are engaging in more objective type episodes of binge eating, any use or misuse of over-the-counter diet pills, laxatives, or diuretics. I've been seeing over the last couple of weeks a lot of news stories and social media posts about that laxative use is on the rise amongst young people. And that's very concerning as a way to lose weight. And certainly it doesn't mean they have an eating disorder, but those are all behaviors that can lead to the development of an eating disorder, because the reality is most people don't wake up one day and say, hey, I think I'm going to have this eating disorder. They may go on a diet, they may be really anxious, and over time, things kind of turn into an eating disorder. If someone is compulsive or excessively exercising, so what does that kind of mean? That means spending large portions of your day engaged in exercise. If you're more of an athlete and you're involved in a organized sport, maybe you do your sport and you go to practice, but then you're doing more activities once you get home. You're not willing to give up your exercise for other types of social activities or things with friends and family. Those are all red flags. And then kind of a host of other things can happen when people are really struggling with eating disorders: increased social isolation, kind of irritability or moodiness, fear of gaining weight, more rigidity around food and eating routines, body image distortion, going to the bathroom after meals are some other things to look out for. When possible signs of an eating disorder are noted in a child or an adolescent, intervention is extremely crucial. Because they're in the midst of crucial physical development, they really are at risk for irreversible long-term medical effects, including growth retardation, structural brain changes, puberty delay, or even arrest of puberty. And for females, that is the time where we are acquiring our peak bone mass that has to support us the rest of our life. And so when we notice these things going on with adolescents, we absolutely need to intervene. Treatment of eating disorders. Really best practice in the treatment of eating disorders typically does involve a multidisciplinary team that includes a primary care physician who has training and background in eating disorders to monitor that aspect of the illness, a psychologist or a therapist to implement the behavioral treatment, which is the primary treatment for eating disorders, a registered dietitian to assess and develop an adequate nutrition or meal plan, and a psychiatrist. And although there are not really medications to treat the eating disorders outside of binge eating disorder, where we really leverage psychiatry is that 80 to 90% of people with eating disorders have co-occurring other psychiatric disorders. Most commonly depressive disorders, anxiety type of disorders. And so we use our psychiatrists to address those co-occurring conditions, because when those are poorly managed or untreated, it is very difficult to address the eating disorder. Treatment of eating disorders should start with a comprehensive initial assessment to determine both the medical and psychological status of the individual. Both the Academy for Eating Disorders as well as the American Association of Pediatricians recommends family involvement in treatment of eating disorders in children and adolescents. If you have a loved one or a friend that their child's getting treatment for their eating disorder and the family is not involved at all, that's definitely a red flag that maybe they are not getting best care. And really, it's important to note that the vast majority of patients really only require an outpatient level of care. So here at Melrose, only about 15% of the patients we treat here ever need a higher level of care. That includes partial hospitalization and up. And we treat about 4,000 patients here at Melrose Center across our 5 sites. Some of the goals of treatment that we're working on when someone is in treatment: first and foremost, we want to stabilize the medical condition, restore or stabilize weight. So it is important to note across the eating disorders, Not everyone obviously is underweight, as we've discussed, but typically people who are struggling with eating disorders do experience some pretty wide weight fluctuations. And so one of our goals is to stabilize that out, help interrupt and reduce eating disorder behaviors and symptoms, help that individual reestablish kind of more regular eating patterns. Again, regardless of the eating disorder, oftentimes when people are struggling with an eating disorder, their eating patterns can become very chaotic and not planned. Help teach people new behavioral strategies and skills. And so I think it's really important to remember that eating disorders, yes, there is an aspect to them that is about food, weight, and eating, but oftentimes there are lots of things going on kind of underneath the surface of why this person is continuing to engage in that eating disorder. So it could be to help manage emotional distress, just stress going on in their life, interpersonal challenges, those sorts of things. So what we're trying to do is teach them other ways to deal with the eating disorder, or other ways to deal with those things other than using eating disorder behaviors. And then help teach people about relapse prevention, because we know people with eating disorders do have a higher rate of eating disorders. So what can you do if you're concerned about someone? I always say, don't watch and wait. If you really are suspecting someone has an eating disorder, or they have a history of an eating disorder, and you see some red flags, taking a moment to express your concerns and offer to support them in getting help. Why is that? Because we really know with eating disorders, there seems to be this window of recovery in which people have the best chance of making a full lasting recovery if they can get treatment and get to recovery within about 5 years. I have seen some more recent research studies that are suggesting a 3-year window, but I think the message is pretty clear that prompt diagnosis and treatment is really important to set people up for success. What can you say if you need to talk to someone? I really tell people, if you are concerned about someone, taking a moment to kind of reflect and think about it, even write down what you might want to say before you kind of dive in with the person, and really focus on using I statements and behavioral observations. Being able to voice what you are seeing and what you're concerned about. I'm concerned because I've noticed that you stopped eating dinner with us, for example, or I'm concerned because it looks like maybe you've lost weight. Really asking them some specific questions, and really offering to help them get help. So really, I'm concerned about you. How can I help support you in getting the treatment you need or getting an assessment? Those are ways to kind of help open the door a little bit to have a conversation. And these can be hard conversations because oftentimes people with eating disorders, they have shame, they have guilt, and they don't always want to give up the eating disorder. And so having these conversations can kind of elicit a bigger emotional response. So there are lots of exciting things happening at Melrose Center, and I want to take just a couple minutes before we open it up for questions to share some of these exciting things. One thing I really want to highlight that also can be a resource to everyone is our podcast, Melrose Heals. So if you haven't heard about our podcast, we actually used a generous donation to launch our podcast and to fund this. So we started this podcast back in the fall of 2021, yes, during the throes of the pandemic. And one of our psychologists, who is brilliant and amazing, Dr. Karen Nelson, is the host of our podcast. So really our goal with this was to host discussions about topics that impact people and families who struggle with eating disorders. And our goal really was to reach people, not only our own community here at Melrose, but beyond that. And I would say we have exceeded that goal. So we have had 50 episodes through the current time and about 29,000 downloads across the world. And so it's really exciting for us to be able to reach people in a different way. We know we have had patients come in for treatment after listening to our podcasts. We know a lot of family members who have benefited from this. And it's a whole range of topics, not only kind of more clinical types of information about different treatments, but also patient recovery stories, which we know are extremely powerful to people and family members struggling with eating disorders. So that is one really exciting thing that has been happening, and I really encourage people to check it out. It is free and it's on all of the main podcast platforms. We also have a really growing special needs fund here at Melrose. Over the last year, we were able to use this fund to help 70 patients and families who were in our care and had items they needed. And how we use the special needs fund is across a variety of ways. In everything from personal care items, clothes, grocery and meal vouchers, transportation vouchers if people can't get here, maybe they don't drive. We have Uber cards, we have gas cards, because people have more and more barriers to getting care, and we want to help people get the care they need by supporting them in that. And so that's another exciting program that we have that we're really proud of. And then finally, this is really big. We are just kicking off an expansion here at our St. Louis Park site. So I mentioned in the beginning, we actually moved to this site. I think it will be 15 years next month. And we received a very large gift to support facility improvement and expansion, specifically here at St. Louis Park. And so really, as I've mentioned throughout this talk, our residential program is really serving an increasingly large range of ages, and our census has been higher. And so we have a lot of shared common spaces, as well as we continue to have a double room occupancy in almost all of our bedrooms here at Melrose. And that's just really not ideal in terms of being able to adequately support separate needs of both adult patients as well as adolescent patients and their families. As I mentioned, we've seen this huge influx of adolescents seeking care here. And really, over the last 4 years with the pandemic, there's been lots of shifts in kind of staffings and programming and how we deliver care, much more telehealth. And that's really resulted in some underutilized space in our building that we feel like we can repurpose that. So we did a big project called a 3P 2 years ago to actually launch this. And we used 3 key words to help guide us. Those words were innovate, experience, and efficient. And so really, in terms of being innovative, we really want to make sure our design of our building and our program around that is for today and how we expect our future state to look, and not just hang on to things because that's the way we've always done it, but we want to continue to provide innovative care here. We want to provide very patient-friendly and family-oriented experience here, and we want to maximize the use of our space in terms of being efficient and good stewards of not only our space, but our donors. So kind of some of the high level things that we're doing here is we are converting all of our bedrooms here so that we will have single rooms across our building. We will have better space for family members, parents, to be able to stay here with their child. So there's adequate sleeping arrangements and shower facilities. Also improve family space, so when parents are here and maybe they're trying to work during the day, that there's better space for that. Have better separation of our adults and adolescents. Add and expand our group rooms so people have a comfortable space and we're not kind of crammed in like sardines. Expand our school space to support our growing number of adolescents, and have, again, expanded dining space so people are not so crowded. So it's really exciting. We actually just kicked off our design portion of this project yesterday, and we expect that construction on this remodel and expansion will start later this year, probably in the fourth quarter. So that is all I have. And so we have some time for questions.
Awesome. If you guys could just, if you have any questions, please enter them into the chat here. Heather, thank you so much for such an excellent presentation. This has been amazing. In the meantime, while we're waiting to see if anybody else has any questions, first of all, I wanted to say I really appreciate how you provided so much research and insight into common misconceptions about eating disorders and everything like that. Could you speak to different types of programmatic actions or initiatives that Melrose Center is doing to address those diverse needs of patients?
Yeah. So it's, this is actually, I would say we are working on this very hard here at Melrose Services, but also kind of in the field of eating disorders, we're really recognizing we need to expand and really understand how do we best treat males? How do we best meet the needs of transgender individuals and diverse communities? And so, really what we are trying to do is look at how do we provide kind of the things that everyone sort of needs, and then also how do we individualize things? So we're making sure that we are offering foods that are pleasing to a wide range of diverse communities and cultures. Leveraging our partners in interpreter services. We just had a great training this week from interpreter services, and we actually did a training with interpreter services so our interpreters understand eating disorders and our treatment better. So when they're providing those services, we both feel like we're giving good care. And then continuing to learn and adjust our program to be innovative. I think we always need to be looking for ways to improve. How do we meet some of the more unique needs of men? Because men are different in terms of kind of how their eating disorder affects them. So.
Thank you so much for that. And we have lots of questions for you. I'll just read them off to you. The first question we have is, what do you believe is causing the rise of eating disorders?
Yeah, I think it's a host of many things. And really, we live in this huge culture of body and dieting and kind of this ideal body image, and more pressure from all angles to have kind of this body image. And I think with social media, that is really, really probably more harmful to people than kind of old school traditional media like magazines and movies, where people of all ages really are being bombarded with these images. And even if you think about how kind of social media works, if you search, healthy quick meal ideas, in your Pinterest or in your Instagram or Facebook or whatever social media platform you prefer, what starts to happen? You start to get served up more and more content about healthy meals, and then that turns into diets and so on and so forth. And so really, we also have these young minds that aren't critical thinkers, and they're getting bombarded with this. And let's get real, the last several years of our world have been very stressful. People have been more isolated. There's been a lot going on. And so also this idea that eating disorders can be a way to help people kind of cope and navigate life.
Thank you so much for that. I appreciate it. Our next question is, are there services at Melrose for overweight or obesity in young people?
So we do treat adolescents who are diagnosed with binge eating disorder. That may or may not mean that they are in a larger body, but in terms of like weight management or medical weight management, that is not something that we do here at Melrose Center. We actually do provide the psychology staff for our organizations weight management and bariatric surgery program, but it's not a service we provide here.
Thank you. Our next question is, do you guys have a specific list of primary care providers that you are recommending to patients after discharge?
So typically, if people discharge, we actually recommend that they continue in outpatient care for us. One thing that's important, I think, to note is that really, if someone needs a partial hospitalization or residential stay, that's like one small first step of their journey, and that the vast majority of their work happens during outpatient. And so our typical recommendation would be is that you can kind of continue to follow with an outpatient team that has training in eating disorders. If someone is maybe from a long distance, we actually do work with primary care providers in different communities. One of our medical providers just the other day was on a long phone conversation with a primary care provider in a small town trying to help guide that individual and how they can manage this patient who discharged. And then we also have a list that we keep of medical providers in the community, primary care providers who we know are health at every size friendly for patients that we treat who have maybe had not welcoming or positive experiences with primary care providers around weight and body issues.
Wonderful, thank you. All right, and one of our other questions is, could you talk about what a typical inpatient day is like at Melrose?
Yeah, so a typical day really is a variety of things. First and foremost, when people are with us, there's obviously a lot of focus on meals and eating and practicing that. And so typically when patients wake up in the morning, they get their vitals and weights taken, there's time to shower, and then there's breakfast. And so throughout the day and evening, we do have 3 meals and 3 snacks for all of our patients. Some of those meals might be eating experiences with their family or a support person. And then in between those, people are going to different types of therapy groups. We have strategy groups, we have problem solving groups, we have skills groups, we have groups led by our physical therapists. So things like stretching, strength, yoga, mind body, as well as our occupational therapists. So really kind of, cooking groups, learning how do you kind of make a grocery list and go to the grocery store and navigate that. So it's kind of a wide variety of things. And then at some point during most people's stay, they may also have time to leave the building and go practice for 2 hours or 4 hours. Our average length of stay is around 17 days here.
Thank you for sharing that. And I think that it's just wonderful that the overall treatment approach sounds so holistic and integrative and everything like that too, to the patient's needs. And we have one more question. What is the annual budget for Melrose?
The annual budget. That is a really good question that I should know the answer to, but I'm so clinically focused. Oh. Let me try to find that out actually, because I see there is one other question about how do we help parents understand the seriousness of ARFID or OSFED. It's really hard to convince them that their child needs the proper treatment. And I would agree with that wholeheartedly. It looks like this is Dr. Decker, who's a physician. We are actually seeing that more and more even here with parents when they even come here for their assessment. They are really not always wanting sort of the recommendation to enter into treatment or when we recommend admission. So, I think really our recommendation and approach is to continue to underscore kind of the serious nature of how eating disorders can physiologically impact people and the kind of long-term damage they can do, especially for young people, but all people. And sometimes those medical consequences don't really motivate adults, but a lot of times with parents, if we can kind of work to continue to educate them using growth charts, using any type of data we have to try to underscore the importance. And I always like to tell people, if you take time on this end and do it kind of well and devote the time you need to do the stay, do the partial, do the appointments, within a couple of, 2 or 3 months, it can put people on a whole different trajectory, and you can save time in the long run. And I think it is important to note that really kind of 28 to 25% of people can really go on to develop more long-term chronic severe eating disorders that can wax and wane through someone's life. And so I think it's continuing to drive that message home about how serious this is, and you need to intervene, and you need to intervene with people that know eating disorders, because the treatment we provide is really different than, a general mental health practitioner.
Thank you so much, Heather, and thank you for such an excellent presentation, and thank you all for attending. If you have other questions that pop up after this presentation, I'd be happy to forward them over to Heather, but in the meantime, thank you everyone, and we will talk to you all soon.
All right, thank you very much.
Yeah, thank you. Bye-bye.